Staffing Ratios and Patient Mortality by Amelia Burrell. So the underlying issue here is staffing. So have you ever worked a hospital shift and you get there and you have, say your usual is maybe 4 patients and tonight you're being asked to take 6. You instantly realize like your workload is now increased. And you have very little time to spend with each one of your patients individually, and maybe you even miss some care and some important interventions and assessments that could have maybe helped your patient to have a better outcome. So unsafe staffing increases incidence of patient safety events, also patient mortality rates, and length of stay in the hospital. Contributing factors include things like the staffing costs. It's rather expensive to train and retain RNs, estimated at like $80,000 a year. Also, workload contributes to staffing issues, patient turnover rates, and burnout in nurses. So I looked at 5 different studies that all talk about staffing and looking at ratios and patient outcomes over long periods of time. The first study that I looked at examined the association of nurse work environment and safety climate on patient outcomes. This was a cross-sectional secondary analysis. This took place in acute care facilities in California, Florida, New Jersey, and Pennsylvania. So they looked at basically the implementation of safety measures alone as not being predictive of patient outcomes. So say things like your fall bundles, sepsis bundles, stuff like that we normally do because we realize it helps keep our patients safe, but at the end of the day, the workload some of those things take to perform outweighs the benefit. They've also found that more organizational intervention should be concerned with improving nurse work environments. So your staffing ratios, it should be looking more at like the sustaining measures that you're performing to keep your patient alive versus just like safety issues alone. Study number 2 looked at the relationship between nursing workload and staffing ratios and the threshold above which mortality is increased. This was a retrospective analysis. They found that exposure to as little as 1 day of high workload and staffing ratios increases mortality rates in the ICU. That's kind of a scary thing to think about because here lately in our own ICU, we normally have a core of 4 nurses, but usually, if we're lucky, we've had 3 nurses on every shift the last several weeks. So they also found conversely that when you have adequate staffing, it reduces that mortality rate by the same percentage. Study number 3 looked at the association of registered nurses and nursing support staffing with inpatient hospital mortality. In this study, they also looked at turnover rates and how that workload increase on nurses also contributes to mortality in patients. The cumulative staffing levels in 3 large U.S. hospitals. So this study occurred from 2007 to 2012 and examined patient outcomes in these facilities. They found that low registered nurse and nursing support staffing were associated with increased mortality rates. Surprise, surprise. Study number 4 examined the association between daily staffing levels and in-hospital mortality rates. This was an observational study, used routinely collected data. This study was similar to the other one that was conducted, study number 2, I believe. Found very similar things here, that mortality rates increased by the same percentage and then conversely were decreased depending on staffing levels on each shift for that unit. Lower registered nurse staffing and higher levels of admissions per RN are associated with increased risk of death during admission to the hospital. Study number 5 is a little bit different. They looked at more the relationship of nurse-to-patient staffing ratios and sepsis bundles on patient outcomes. They found that the implementation essentially of the sepsis bundle alone was not enough to reduce mortality. What had more of an effect on these patients who were diagnosed with sepsis was in fact nursing ratios. If that patient had fewer hours with nursing staff, they were more likely to have a higher mortality rate. So each additional patient per nurse is associated with 12% higher odds of in-hospital mortality, 7% higher odds versus like 60-day mortality rates, and then 7% higher odds of 60-day readmission and longer lengths of stay overall. So some solutions to this, basically hospitals need to, and federal regulations, I should say, need to invest further in making the environment conducive to nurses' work, to nurses being able to provide that holistic care to patients, having adequate staffing, and actually having support from administration and management to be able to do those things. I think in the long run, if we had better staffing ratios as well as support overall in our work environment, I think we would see better retention in our facilities, and we wouldn't have so many of the issues that we're having now where it literally seems like nurses quit a facility and go travel to another facility a few hours away and get paid thousands of dollars per week to work there, when we could look at, some of the things going on at home and maybe fix those, and we wouldn't have those issues. So here is the proposed federal RN ratios. You can see here ICU is 1 to 2, Med-Surg is 1 to 4, just some common ones. I think those are well within the limitations of what is acceptable. It's definitely hard once you go over those ratios. And then here are my references. Thank you for listening.